Pleasure to welcome Dr. Andrew Lee. Andy, he is a fantastic speaker, and he has many friends here in Toronto that unfortunately we was hoping to visit in person, but it is we are finally coming out of things, but it's still a virtual meeting today. He is chair of the Blanton Eye Institute at the Department of Ophthalmology at Houston Methodist Hospital in Houston, Texas. But he's also professor of ophthalmology, neurology, and neurosurgery at Weill Cornell Medicine. He is adjunct professor of ophthalmology at Baylor, Texas A&M, University of Iowa, and the University of Buffalo, and clinical professor at the University of Texas Medical Branch in Galveston, Texas, as well as MD Anderson Cancer Center. He's been an AAO member for over 25 years and has served in numerous leadership roles there, including as member of the OCAP committee, chair of the AAO Task Force on Aging, and later the AAO Committee on Aging. He's also received an AAO Lifetime Achievement Award, Senior Achievement Award, Secretariat Award, and he volunteers in the Minorities in Ophthalmology Mentors Program. He's also on the AAO NANOS committee and the NANOS representative and treasurer for the University Professors of Ophthalmology, which is AUPO. He's a past president and current chairman of the Board of North American Neuro-Ophthalmology Society and has board membership experience at many levels, including the Board of Trustees at Houston Symphony, treasurer and board of Houston Neurological Society, and the Houston Ophthalmological Society. He is well known for his teaching. He has an interest in resident education and especially enjoys teaching about teaching in ophthalmology. He has actually received the Resident Teaching Award 8 times at 5 different academic institutions, as well as the Excellence in Clinical Education from the Oslerian Academy. So please welcome Dr. Lee.
So great. We recorded this talk ahead of time, so I'm going to let Amandeep play it. We're going to answer the questions in the chat live, but also in live in person because this is being recorded. All right.
Yeah, so please enter your questions in the chat box. We will pause the talk if things come up, and Dr. Lee will be with us the whole time.
Hello, and my name is Andy Lee, and today, hopefully I'm going to be doing something new, but I'm going to talk to you about 5 medicines that can blind your next patient and blindside you. The thing that's new is I'm recording this on Zoom, and hopefully I'll be playing this for you and running on my treadmill at the same time. I have no financial disclosures because I'm a neurop and will work for food. I don't have any proprietary interest in any of the contents of the talk today, but I will be talking about some medicines of which I have no personal experience with the pharmaceutical agent described in terms of taking it, but there's nothing wrong with that, of course. I care about feedback, please make it good, but yes, fill out your evaluations, and yes, say how great it was, but I care more about you and your patients. So the next time you see me at the American Academy of Ophthalmology, stop me and say, you saved someone because of something you heard me say, and that is the most powerful feedback that I, as a teacher, can receive. Also, make sure your feedback is good. But really, at the end, I want to tell you about why you're here and why we're here on this planet. And I believe that there's some version of this written in your personal statement for getting into ophthalmology and probably in the medical school. You wrote, make a difference. And today, we're going to try and be that difference. Because the Reaper is coming. He's coming for your patient's vision. He's coming for your patient's lives. And sometimes the only thing standing between the Reaper and the vision loss or death is us. Because neurop saves lives. And no one dies from missing a cataract. No one dies from missing macular edema. No one dies from that missed LASIK opportunity. People definitely die and go blind from missed ophthalmic disease. And so this talk might require a behavior change from you. It might put you outside of your comfort zone. But if you do it, I think you'll find some reward in that. And so I'm going to cover 5 potentially sight-threatening systemic medications that can blind you, patient, and blind you as a doctor by blindsiding you. And that is the lead hateless, hydroxychloroquine, amiodarone, tetracycline, and ethambutol, little e, the erectile dysfunction agents. I'm going to define for you the specific risk factors for ocular toxicity and the risk stratification strategies that will help you save your patient. And I'm going to describe the key clinical screening for each of the medicines and the recommended tests. So here's the hate list. The medicines that Dr. Lee hates in their op clinic: hydroxychloroquine and chloroquine, which produces a bullseye maculopathy; amiodarone optic neuropathy, which produces something that looks like anterior ischemic optic neuropathy, often bilateral and long-standing, chronic, and persists even after you stop the medicine; tetracycline, but especially minocycline, which crosses the blood-brain barrier, and especially in combination with vitamin A analogs that are used to treat acne, like isoretinoic acid, that produces pseudotumor cerebri; ethambutol, which is our classic toxic optic neuropathy, bilateral, central, or secocentral scotoma. And to warn you that the screening strategy for ethambutol is different than amiodarone, hydroxychloroquine, and tetracycline. And little e, the erectile dysfunction agents. We'll be talking about sildenafil today, even though I have no personal use history with that drug. Not that there's anything wrong with that. It produces anterior ischemic optic neuropathy. And so it has a very distinctive stem. A patient is referred with bilateral simultaneous vision loss from cardiology with arrhythmia. You should be thinking about amiodarone. A patient is referred with bilateral simultaneous vision loss from dermatology with acne. You should be thinking about tetracycline and vitamin A in a patient who has papillary edema. And if they're referred from pulmonology and they have painless progressive loss of vision with a central or secocentral scotoma, Mycobacterium avium complex, or tuberculosis, you should be thinking about ethambutol. And if they came to you from urology with vision loss and has AION, you should be thinking about erectile dysfunction agent, including sildenafil, but also all the other agents in class, Levitra, Cialis, etc. And if they come from rheumatology, this is the one that's the most dangerous because it has a specified screening strategy, whereas the other ones don't. With lupus or rheumatoid arthritis, even before the development of ophthalmoscopic findings, we need to screen that person for hydroxychloroquine toxicity, and we're afraid of the bullseye. And so one of the things that's most dangerous is the medicine list, and a lot of the history has become copy and paste. And this leads to sins of omission as well as sins of commission. And so we really need to get that med list right. And so when your patient comes in and has no medical history, and then they show you the med list, that's one of the problems. So do you have any medical problems? No. What are all these medicines for then? Oh, I don't have those anymore. They take care of my high sugar and my high blood pressure. Dr. Lee, frowning face. And so when we look on the med list of these electronic medical records, it's often just like a really long laundry list. You can't really tell which one they're on. And so we always reconcile the medicines at every visit. And it's very tempting when you have an electronic medical record not to do this, because you can just say see list or just let it keep going forward. And it's super dangerous to let these medicines accumulate. And the reason is embedded in that list is something that's potentially blinding to this patient. So the inappropriate medication list, C list, some type of lung medicine, some type of heart medicine, some kind of antibiotic, these are dangerous things in patients who have unexplained vision loss. Because if you don't recognize that it's the medicine that's blinding them, how can you possibly stop it? And that's a neurop disaster ahead. You should know that hydroxychloroquine is Plaquenil, amiodarone is cortisone or caserone. Tetracycline could be listed as quote unquote some type of acne medicine. And sometimes patients don't realize that these acne medicines are real medicines, including the vitamin A analog, which in conjunction with minocycline and tetracycline can cause pseudotumor cerebri. And ethambutol is myambutol. Of course, the erectile dysfunction agents, it's going to be very difficult sometimes to get the patient to admit they're using that, especially if they come with someone else, because they might not be using that agent in front of that person with that person. And so it's really important that we ask them erectile dysfunction agent questions without that other person there. And it's harder and harder to keep up with the names of these medicines. And so I just want to share with you what I use for kind of deciding whether something has a cause and effect relationship on a day-to-day basis, even though these are epidemiologic criteria. Is there a biologically plausible mechanism for this drug to cause this effect in the eye? Is there a close temporal relationship between the cause and effect? Is there an analogy from experimental or animal or other human evidence that this drug does this effect? And we're going to Google that, of course. Is there coherence in class? Do drugs in the same class cause the same problem? Is there a dose response biologic gradient that I need to know about for a drug, for example, with ethambutol 15 milligrams per kilogram, or for hydroxychloroquine 5 milligrams per kilogram, or higher dose risk thresholds 6.5 milligrams per kilogram for hydroxychloroquine? Is there effect specificity, including chance alone? That is, there's no reasonable alternative explanation for the patient's vision loss. And then ideally, there'd be a D-challenge, take it away, they get better, and a re-challenge, they give it again, and they get worse. Most people don't want to have a re-challenge. So if we just start with the little e, erectile dysfunction agents, there is a biologically plausible mechanism how an erectile dysfunction agent could cause non-arteritic anterior ischemic ophthalmopathy. Now, of course, the garden variety NAION, some people believe that is nocturnal hypotension and hypoperfusion to the optic nerve. And so when you take one of these agents, there is a drop in your blood pressure, about 5 to 10 millimeters of mercury, within 2 to 4 hours after the dose. And for whatever social, cultural, other reasons, these drugs tend to be taken at night, so it could potentially potentiate the NAION effect of nocturnal hypotension. And then there's the other comorbidities that tend to go along with these things, as you know, alcohol use. And so nocturnal alcohol use plus nocturnal erectile dysfunction use plus nocturnal hypotension could lead to nocturnal NAION. So I think this is a weak but biologically plausible mechanism for NAION. I think it's weaker because the drop is so low, 5 to 10 millimeters. But 5 to 10 millimeters in someone who's already at risk could be the threshold effect. You should know there are potential drug interactions with the erectile dysfunction agents, including amlodipine, which adds an additional drop in the blood pressure. And so this paper from American Journal of Cardiology actually recommended that you modify the dose and that there are definite interactions between organic nitrates, calcium antagonists, and the erectile dysfunction agent, in this case, sildenafil. There are more than 50 cases now of NAION in the FDA database. The problem, of course, is this drug is used in vasculopathic males, and so that's why they're taking the drug. You should know also that other indications for these agents, including pulmonary hypertension, means that some patients actually have no erectile dysfunction, and they're taking that agent, sildenafil, for some other vasodilator reason, and that means they don't have to be a vasculopathic male. Of course, in these patients, the males, the risk factors for impotence include diabetes, cardiac disease, and so they already have risk factors for NAION. In the preclinical trial, over 1 billion doses were given, 23 million prescriptions, and 13,000 males were in that preclinical testing. There were no cases of NAION. However, it does have a coherence with taking the drug in terms of the temporal relationship that is coherent with the pharmacokinetics, the half-life, and the peak dose. And I already mentioned to you the presumed mechanism for some of these cases is the erectile dysfunction agent is taken at night, and the nocturnal hypertension compounded by the drop in the blood pressure is within the time period of NAION, and they wake up the next morning with the vision loss. A lot of the cases, however, are not within that peak 2 to 4 hours. Now, that's because they have it in the night and they wake up in the morning. But I'm less convinced by cases of erectile dysfunction agent once you get beyond the first day. However, in the studies, they looked at exposure in the first month within the NAION. And so the strongest temporal relationship are in the cases that are close to taking the drug and usually the same night, but I allow it to be plus or minus a month when I'm considering possible causation. There's no testing in animals. We have an NAION model, but not for this. And there's case control data, but it's weak. And the uniformity in those cases is lacking. However, there is some evidence for coherence within class effect. For the other erectile dysfunction agents, it doesn't look like toxic optic neuropathy, however, and I'm going to talk to you about that because ethambutol is our classic prototype for toxic optic neuropathy. Bilateral, it has a clear dose response, biologic gradient, papillomacular bundle involvement, central central involvement, and produces the retrobulbar optic neuropathy. So ethambutol toxicity doesn't look anything like erectile dysfunction agents. The closest analogy that we have is amiodarone optic neuropathy. So both amiodarone optic neuropathy and erectile dysfunction agent-related optic neuropathy seem to converge on the thing that looks like NAION, non-arteritic anti-ischemic optic neuropathy to us. And so I don't think erectile dysfunction agents actually cause toxic optic neuropathy. That's ethambutol or a toxic retinopathy like hydroxychloroquine. I think it's more like there's an A cause B and B cause C effect, and that is plausible. And as I mentioned, normally with toxicity, there's this dose response curve, and that's clearly the case in ethambutol, 15 mg per kg, and hydroxychloroquine, 6.5 mg per kg. And in dose response curve toxicity, concomitant renal disease and liver disease because of the metabolic excretion of the drugs makes a difference, and weight makes a difference. But in drugs that have idiosyncratic reactions or who are A cause B and B cause C, like hypertension in erectile dysfunction agents, there's no dose response curve. And what that means is there's no screening strategy for these erectile dysfunction agents because there's no dose response curve. So you can't really follow that patient and say, oh, you're getting higher and higher risk. That risk is idiosyncratic. And the same thing is true for amiodarone, and the same thing is true for tetracycline and vitamin A. If there was a dose response curve, we could screen the people. And so the two that have the dose response curve are ethambutol and hydroxychloroquine, and those two you can screen for risk based on dose and duration of therapy. So there doesn't seem to be any dose effect seen in the cases of the erectile dysfunction agent related NAION. There's a re-challenge case where the patient lost their vision and then foolishly just did it again. So they re-challenged themselves. Recovery, not reported, of course. And so that recovery and re-challenge is a very critical part of establishing cause and effect relationships. For example, if you took a medicine and you got Stevens-Johnson syndrome and all your skin and mucous membranes fell off, well, if you got that drug again and it happened again, that's a very powerful re-challenge evidence that the drug caused Stevens-Johnson syndrome. Or if you de-challenge, so in the hydroxychloroquine people, the plaquenil people, if you stop the medicine, sometimes they get their vision back. Same with ambutal. Of course, if the mechanism is NAION, then stopping the medicine is not going to reverse NAION. So stopping the erectile dysfunction agents is to prevent another event, not to reverse the vision that already occurred. So my take on erectile dysfunction agents, including sildenafil, is there is a weakly plausible biological mechanism for NAION from hypotension, especially nocturnal hypotension. There's a weak temporal relationship once you start getting beyond the next day, or I had it after I took the drug the night before and I woke up with NAION. The further away you are from the exposure, the less likely it is to be the cause, especially once you get beyond 5 half-lives of drug, which is presumed complete washout. But I will accept and look at a 1-month interval for exposure. There's a little bit of analogy because there are 50-some cases now. However, there's billions of doses that have been given. There's weak coherence with class because the other drugs do it, but it seems to be more likely in the patients who have the more likely drug, which is sildenafil, because there's more of it out there. There doesn't seem to be a dose response curve, and therefore we don't have a good screening strategy. The effect is not specific at all. The effect is NAION. So that could be because they had risk factors for NAION, because that's why they're taking the erectile dysfunction agent to begin with. There are a few re-challenge cases, and that's the strongest evidence that we have. But we really don't have a lot of de-challenge evidence because once you get NAION, it's not going to suddenly reverse just because you stop the medicine. So if you look at this case control study from Lafayette and McGuinn, they had 38 cases of NAION and 38 age-matched controls. This was presented at Nanos and then published. And males with NAION were not more likely to report the use than controls. I guarantee you if I had a red Corvette, this would not be my license plate. Anyway, this paper was retracted. And the reason it was retracted, and you can see the British Journal of Ophthalmology retracted this paper in 2006, is because it was the source of litigation. And so there was a lot of legal back and forth on this erectile dysfunction agent, and the authors in this paper could not meet the documentation standard, and so they pulled the plug on the paper. So let's just look at the available remaining evidence. So here's the Gorkin et al. Series, and that's the preclinical trial that I mentioned, 13,000 men, 35,000 patient years in the epidemiologic pooled study. Incidence of NAION as the endpoint, 2.8 per 100,000 patient years of use. That's a very low risk. In fact, if you look at that compared against the general population risk for NAION, which is 2.5 per 100,000 to 11 per 100,000 for men in the vasculopathic age range for which erectile dysfunction agents might be used, it's probably about the same. However, because of all the cases and the publicity, negative publicity about the drug, the FDA mandated that the companies perform studies to see if there really was or was not a relationship. And so if you look at this study published in the widely read journal that all ophthalmologists, of course, subscribe to, the Journal of Sexual Medicine, in January 2015, the odds ratio for acute NAION and exposure to a PD5, a phosphodiesterase type 5 inhibitor, was 2.15. And if you included the possible cases, it might be as high as 2.36 of exposure linkage to NAION for PD5 erectile dysfunction agent. And so you can read more about this debate in this little article in AJO on the erectile dysfunction agents and NAION controversy. The current FDA recommendation is, in the event of sudden vision loss in one or both eyes, we're to advise patients to stop the use of the PD5 inhibitor and to be examined. And if it's NAION, I discussed with them the risks of that drug and how they could be adversely affected by future use. The strongest cases are the bilateral, either simultaneous or sequential cases. The cases that have the close temporal relationship to the dosing, 2 to 4 hours within onset of vision loss, or wake up the next day with it. There are the rechallenge cases, of course. And of course, there are some cases where the patient had no vasculopathic risk factor. They were just using the drug recreationally, and that is a very convincing case. So the bottom line is, someone needs to tell the patient, what do I tell the patient about erectile dysfunction agents and NAION? I tell them there's an unknown but probably small risk of NAION. And if you've had prior NAION, you might want to consider or reconsider the risk-benefit ratio and its impact on your quality of life. That hazard ratio is somewhere between 2.1 and 2.3x higher, a small number, which is already 2.8 per 100,000. But in your risk factor range, it might be as high as 2x times 11x, 11 per 100,000. So 2x times 11 is 22 per 100,000. Something in that range is the risk we're talking about at the high end of the spectrum. And I ask all patients about ED agents if they present to me with NAION about taking these medicines. And usually I get one of two responses. Response one, sure, I don't need that drug anyway, just stop. Number two, I'd rather be blind. And what if you don't tell them about the relationship of the ED agent and NAION? Well, they're just going to Google it. So Google can be an angel or a devil. And I love this quote from Abraham Lincoln shown here, that the trouble with quotes on the internet is that you can never know if they're genuine. And I think old Abe had something right on this one. And I think he knew what he was talking about here. I want to tell you a little bit about a different drug, that's amiodarone. If you Google amiodarone and vision loss, the paid sites, amiodarone lawyer, all show up. And so you need to know a little bit about amiodarone, which is antiarrhythmic for cardiac disease. It's the largest lawsuit in ophthalmology history. It was a $22.8 million judgment against Wyatt Harris in 1997 for amiodarone optic neuropathy. The labeling of the drug has since changed to emphasize the possible occurrence of amiodarone optic neuropathy, and that kind of shifted the pharmaceutical product liability issue to a malpractice issue for physicians who prescribe or follow these patients. And you know that amiodarone has this ocular toxicity, and the side effect of the drug, which is dose responsive, it's a very specific finding because it's a vortex keratopathy. And if you de-challenge the person, it goes away. And if you re-challenge them, the vortex comes back. In fact, we can use this to see if you're taking their medicine. So it's this vortex or verticillata keratopathy in the lower cornea there. And that is a known association of the drug, amiodarone keratopathy. However, there's this other amiodarone finding, which is called amiodarone optic neuropathy rather than keratopathy. And the strongest cases, if you look at these papers, are bilateral, insidious onset, slowly progressive, protracted disc swelling, and it takes months for this swelling to go away. You should know, though, that if you have bilateral disc edema, you have to work that up because there's no test to prove it's amiodarone, because it's one of those not dose response, dose dependent. There's no go to the lab and get your amiodarone level test and we'll find out. It's a clinical diagnosis. So for these cases, you really have to look for other causes before you blame it on the amiodarone, but you should consider the amiodarone toxicity in every patient who is on this drug who develops an optic neuropathy. And the reason you shouldn't stop the medicine is that's not your job. Your job is not to make the call. Your job is to make the call to the person that makes this call, which is a very high stakes decision because amiodarone saves lives. It's not dose dependent. It's in a minority of the patients as opposed to the keratopathy, which is seen in almost every patient. There's no proven pathogenic mechanism. It looks just like NaION, so it's like the problem of the erectile dysfunction agent NaION. And of course, these patients have other vasculopathic risk factors. There's a de-challenge problem because you stop it and they don't get better. In fact, it can continue to get worse because the half-life of the agent is very long, the drug deposits in tissues, and so you really have to have high suspicion and work this up before you'll be comfortable with the diagnosis of amiodarone optic neuropathy. In the Mindell study in the American Heart Journal in 2007, amiodarone versus placebo, they followed the patients for a median of 45.5 months. The endpoint of the study was, did anybody have bilateral vision? Worry about it. So what to tell the patient? I tell them, look, you are on amiodarone. There's a risk of amiodarone optic neuropathy. There's no screening strategy for this. The risk factors for taking amiodarone overlap with your vasculopathic risk factors for non-automatic anterior ischemic optic neuropathy. If they've had it before, I warn them and I warn their cardiologist. I tell the patient, look, I'll make the call to the person that's going to make the call, and that is not me. I will call your cardiologist about your medicine. And you need to make a risk-benefit decision with cardiology or medicine about the risk-benefit of taking this medicine. And just like the erectile dysfunction agent, I usually get one of two answers. Answer one, sure, no problem. He can stop that agent. Answer two, he'll die without it. And so you cannot use a one-size-fits-all approach to this. I love this. Some employee was instructed to put all these different wrenches with different sizes up here, and it's supposed to be the different fixed size wrenches, but they put the adjustable wrench. So you need to use a adjustable wrench, but not for every single circumstance. There are some protocols you should follow for these agents, and you have to develop your own protocol, I guess is what I'm trying to tell you. So look at this patient. She's a 65-year-old female with lupus. She's on hydroxychloroquine, Plaquenil for the past 8 years. She's reached current dosing 6.5 mg per kg at a cumulative of 1.6 kilograms. She's not obese. She's got no liver, renal, or macular disease. She had a Humphrey 24, which is a non-specific scatter, and her eye doctor did a 10-2 and said, well, maybe it's a homonymous hemianopsia on the right, and referred to her 5 months later. So this is not the right strategy. So as soon as someone who's on hydroxychloroquine has any visual field defect or any visual complaint at all, you must consider the possibility that it's toxicity, as opposed to amiodarone and the erectile dysfunction agent, which have no dose response curve. Hydroxychloroquine definitely has a dose response gradient, And the risk increases when your dose is over 5 milligrams per kilogram, but it's much higher if it's higher dose. So 6.5 mg per kilogram is kind of the toxic threshold. You're starting to think, okay, I'm worried about that. Even though anyone over 5 mg per kg, you still have to watch that person. And the cumulative dose threshold, 1 kilogram. Once you get above that, you're starting to get worried. And of course, the older you are, the more likely you are to get the toxicity. So this person's 65. And so once they do the field and they find the abnormality, you can't be fooling around with a neuro-op appointment 5 months later. And so I tell the medical students, look, you have to know something about these numbers and letters. 10-2, Humphrey, not 24-2 unless you're Asian. Fundus autofluorescence, not fundus fluorescent angiogram. Spectral domain, not time domain OCT. And multifocal ERG if you're going to use an ERG, not a full field ERG. But to the medical student, it sounds like this: 10-2, not 24-2, FAF, not FFA, SD, not TD, OCT, and MERG, not FFERG. Then the medical student says, I didn't understand what you just said. It sounded like just a bunch of numbers and letters. And so in order to avoid that, let me just walk you through what you should be doing. You should be doing a Humphrey visual field or other automated perimetry of the central field, a 10-2, because it's a bullseye maculopathy that you're looking for, and not a 24-2. But Asian people sometimes have this paracentral form, and so we often end up doing a 10-2 and a 24-2 in Asian patients. Fundus autofluorescence is what we're going to be doing, not fluorescein angiogram for our screening. And because it's a central problem, a multifocal ERG, not a full field ERG. And if you're going to do OCT, we need spectral domain, the higher resolution OCT, not the time domain OCT. And we need OCT of the macula, not the optic nerve. You can use lamps or grid, but that's for the patient at home, not for the office. For the office, we should do some type of formal perimetry, central field, plus one of those other tests. You don't have to do all 4. We can do a field plus either fundus autofluorescence, a multifocal ERG, or spectral domain OCT of the macula. You don't have to do all 3, but you have to pick one of those. And we're going to risk stratify people. If they're high risk, we see these patients quarterly. If they're low risk, just follow the regular, normal American Academy of Ophthalmology guidelines. The toxicity of hydroxychloroquine, its mechanism is not completely understood. It produces a bullseye maculopathy in the center of the vision. It's bilateral. Once the bullseye develops, it's irreversible, and it can continue to progress even after you stop the drug because of the long half-life and the drug deposits in tissue, as you saw with the amiodarone keratopathy. Even though the PDR recommends quarterly eye exams for everybody, I think this is excessive. Many authors have questioned the need for this, and that would likely overtax the system. And so what I tell the patients is, if you're on this drug, it's a dose response thing. We're going to follow you. Normally, we don't have to worry about it until year 5 of drug, but if you're on high dose and have risk factors like liver and renal toxicity, or you're older, or you have pre-existing maculopathy, you might follow that patient longer and shorter intervals. And I tell the patients any visual complaint, flashing eye, light sensitivity, decreased vision, and I give them the answer grid, but that grid is for them at home, not for the office. What we're looking for is this bullseye maculopathy. You can see the RPE change here in the macula. And on the Humphrey 10-2 ring scotoma. So ring scotoma, you can stick your finger right through that ring right there. That's a retina field that correlates with the bullseye maculopathy. It can also look like a central scotoma, and you need to know that 24-2 might be necessary in the Asians because they have this paracentral form. And on the spectral domain OCT, as you know, the different layers of the retina, and the one we're going to be looking at is this ellipsoid zone here, the IS-OS junction. And so you can follow the train track. So you should be able to ride a train all the way along this track. But here, right in the parafoveal region, both sides of the fovea here, we have this parafoveal disruption of the IS-OS junction in the ellipsoid zone, corresponding with what eventually will be ophthalmoscopic like a bullseye. And so it's very important that you have magnified views with high magnification and high suspicion of that inner segment, outer segment line, where the end of the cone outer segment tip line is. That's where the train tracks diverge, or there's disruption of the train track. So If you just look at the train track here, you got 2 tracks passing right through the fovea, and then right when you get over here, you're starting to lose the train track. Multifocal ERG is very sensitive, but the problem is it's not universally available. I use it when I don't have reliable indices on the other parameters or as an adjunct, but most places don't have MERG. You can see on this multifocal ERG different waveforms that are multifocal, and then there's depression in the paracentral region that's corresponding with the plaquenil toxicity. And fundus autofluorescence, not fluorescein angiogram. This is an autofluorescence, and you can see the slow development of the bullseye maculopathy, and that's visible to the fundus autofluorescence FAF before it's visible to the naked eye. You should know that chloroquine is way worse, so if they're on the chloroquine, I follow the PDR high-risk guidelines for that. And please don't wait for the development of the bullseye. By the time this bullseye thing occurs, that's game over. So you should be worried about chloroquine a lot more, because that's why hydroxychloroquine was developed, because the toxicity threshold was so high for chloroquine. And so we have to worry about chloroquine at doses and durations that are much shorter and much smaller dosing than hydroxychloroquine. And if you wait for that bullseye to appear, that's game over. If the bullseye appears on your watch, that's a big problem. And of course, please don't use that 24-2 alone for hydroxychloroquine. We need that for Asian patients, but you have to do the 10-2 on both Asian and non-Asian patients, because it's this paracentral loss. And the reason is, on the 24-2, it might look like nothing, a non-specific scatter, and then all of a sudden it's a central scotoma or a rhinisticum. So once you get parking in the wrong area, it'll cause the other cars to actually park in the wrong area. So the first field on the hydroxychloroquine has to be the 10-2. The first screening test has to be the spectral domain OCT, fundus autofluorescence, or MERG. Because if you don't, if you start with the 24-2 or you start with the fluorescein, then next time you'll do the same bad thing and the next thing and the next thing. And so everyone will end up parking in the wrong place. So you need to know that unlike the idiosyncratic reactions like tetracycline and amiodarone and erectile dysfunction agents, this has a dose response curve. So low risk patients, less than 5 mg per kg, higher risk, 5 to 6.5, total cumulative dose, 1 kilogram, duration, 5 years or more, higher risk. Obese patients, if they have concomitant excretion problems, renal, liver, or maculopathy, you should be very worried if they're on concomitant tamoxifen and if they're older. These are higher risk patients. If you look at the adherence to the American Academy of Ophthalmology guidelines for hydroxychloroquine screening, this was a paper published in HAO, 560 patients, only 54.8% of the people were complying with the guidelines. That's shockingly poor. So what are the guidelines that I follow? I do a visual field, 10-2, plus one of the above. MERG, spectral domain OCT, fundus autofluorescence. You don't have to do all 3, but you have to do one of the above. If it's abnormal on the 10-2, you should take that seriously. And I think MERG eventually will take the place of visual field, but right now it's not. And the AMSA grid is not recommended for in-office use. You should use a 10-2 and ask about tamoxifen. So do this, not that. Do a 10-2, not a 24-2, unless you're Asian, when you may need both. Do a FAF, fundus autofluorescence, not an FFA, a fundus fluorescein angiogram. Do an SDOCT, spectral domain, not a TDOCT, a time domain, spectral domain, OCT of the macula. Use the AMSA grid for home for the patient, but not in the office, and risk stratify the patient. High risk based on dose, duration, cumulative dose, mg per kg, concomitant renal or liver disease, their age, and also whether they have pre-existing maculopathy, and especially watch out for that tamoxifen. If they're low risk, I just follow that patient annually. I'm going to switch gears and talk to you about acne in a young female, or in this case, a young boy who has severe acne. So the young female is dangerous because it overlaps with pseudotumor cerebri. So young, obese female, might look like pseudotumor cerebri, but it's the medicine, tetracycline, but especially minocycline and isoretinoic acid. But what if you change the stem from acne in a young female to a 16-year-old boy with severe acne? Well, well, that means you really have to worry that it's exogenous agent. So once it's a male and not a female, once it's a thin person rather than an obese person, once it's a kid versus an adult, you really need to thinking about minocycline and Accutane, vitamin A, or any of the vitamin A analogs as a secondary cause for this patient's headache, blurred vision, ringing in his ears, and papilledema. In the PDR, the pseudotumor cerebri warning appears as this. Accutane use has been associated with a number of cases of pseudotumor cerebri. Some cases involve concomitant use of tetracyclines. Concomitant treatment with tetracyclines should therefore be avoided. Well, nobody is doing that. Almost all the patients are being treated with concomitant combination therapy of some kind, minocycline and vitamin A analog, isoretinoic acid. So you're going to see this, and the combination of the two agents increases the risk, but I don't think anybody's following this. So young obese female is typical IH. You still have to think about tetracycline and exogenous agents, including vitamin A analogs, but especially thin, elderly male or 16-year-old boy with acne. And of course, you're going to ask all the usual questions. And the ones we're talking about today are tetracycline, but especially minocycline in combination with the vitamin A derivatives. And you see the rest of the list there. I want to end with ethambutol. Ethambutol is the prototype for toxic optic neuropathy. It causes a painless, progressive, bilateral loss of central acuity and central field. It has a proven causation, which is dose-related. 15 mg per kg versus 25 mg per kg versus 35 mg per kg definitely increases your risk of toxicity and going blind. It causes a blue-yellow rather than a red-green dyschromatopsia, and the central or secocentral scotoma is the classic finding. The disc is normal. The doctor sees nothing, the patient sees nothing, and then later, temporal pallor will develop. Please don't wait for the temporal pallor. Just like don't wait for the bullseye. Don't wait for people to be blind to do something about it. And the recommendation is to screen high-risk patients. High risk is high dose. The dose threshold is higher than 15 mg per kg per day, or if they have concomitant renal failure or are suspected of having the disease for a long time and requiring long duration therapy. And somebody has to check their vision every month. They don't have to have a full eye exam. In fact, it could be anybody checking their vision, but every month someone has to check their vision. I would say the patient should just check their vision every day, but you know how that goes. And we warn every single patient about the toxicity. I recommend they have a baseline examination and a baseline visual field. As opposed to hydroxychloroquine, it probably doesn't matter whether you're doing a 10-2 or 24-2 here. I do a dilated fundus exam to document if they have pre-existing maculopathy or document what their nerve looked like before. I also do a baseline OCT to make sure their nerve is normal. And I tell them if there's any change, come in right away. And so in the Homeland Security risk stratification for ethambutol toxicity, this is all about dosage. Dosage. So if you're in the highest risk category, you really have to watch that person. And as opposed to hydroxychloroquine, which is like 5 years later, this is going to happen like in 5 days or 5 weeks or 5 months. So you really have to watch these people. And so it's really dangerous, and danger, Will Robinson. So please don't confuse the two screening strategies. Look at this chart. It says impression, no evidence of ethambutol toxicity, plan 1 year. That's not the correct strategy. Someone has to check this person's vision every month. And I think the patient should check their vision and their answer every day, but whatever they can do. In addition, weight loss during the treatment. So they usually have some underlying pulmonary disease, lung transplant patient with mycobacterium, or they have tuberculosis, and they often lose weight during the treatment. And so that weight change will cause dose change in mg per kg. So you got to watch out for the mg per kg. So here's the British Thoracic Society guidelines for chemotherapy and management of tuberculosis in the UK. The guidelines are old. However, here's what they recommended: inquiring monthly about visual symptoms is advisable. And so I think somebody has to check their vision. And we give them a little copy of the near card, and they just check themselves and an answer grid. And the issue, of course, is no matter where you are, TB is there. But 22 countries have 80% of the TB, and they all seem to be wanting to migrate to me or to you. And some scary math, this is from my friend Alfredo Sadu, ethambutol optic neuropathy. And if you look at the numbers of people who have tuberculosis and Mycobacterium avium complex, how can we prevent 100,000 new cases of iatrogenic blindness? These people were blinded by their doctor, not by their disease. 100,000 people. And so it looks like this, a secocentral or central scotoma. It often breaks out to the temporal periphery, kind of mimic a bitemporal hemianopsia. So we image these patients, but we stop the medicine too. You have to make the call to the person that makes that call, and that's not you. You cannot be stopping people's ethambutol. You have to call someone to do it. And at 15 mg per kg, about 1% of people are going to lose their vision. Once you start getting to 25 mg per kg, about 5% of patients are going to lose their vision. So if you look at the older literature from the TV literature days, this is Libo, 1966. Once you start getting into the 35 mg per kg range, look at 18.6% of the people are going blind, versus only 2 of 59 cases, 3.3% when you were below 30 mg per kg. At 25 mg per kg, you had a 6% risk of vision loss versus 1% at 15 mg per kg. And of course, renal disease is its major risk factor. And so the current recommendation is that somebody check their vision once a month. And if you look at the Joint TB Committee from Thorax, the renal function needs to be assessed before starting the drug. And I try and convince them to use something else if they have other choices. If the person has renal failure, so we contact the primary prescribing doctor about the risks. I say they should only get the exact dose and duration calculated to what they need for that particular agent, whether it's Mycobacterium complex or Mycobacterium tuberculosis. I think everybody should have a pre-treatment baseline visual acuity, OCT, and exam, including a field, so that we know what they look like before. And I try to convince the doctors to avoid ethambutol if the person already has visual impairment, like age-related macular degeneration. And I document all of that discussion, both with the patient and with the doctor in the chart. So in summary, hopefully you've seen what medicines that Dr. Lee hates. I hate hydroxychloroquine, but I especially hate chloroquine, which causes a bullseye retinopathy. You need to risk stratify that person and then follow that person with the specific screening strategy that I've recommended to you based on dose and duration. Amiodarone optic neuropathy, A, causes anterior ischemic optic neuropathy. It's usually bilateral, insidious, and can linger on even if you stop the drug. Look at their cornea for that amiodarone vortex keratopathy. T, tetracycline, but especially with the vitamin A analogs like isoretinoic acid, produces what looks like pseudotumor cerebri. You should be thinking of that in every patient, but also the typical patients, females with acne, but especially the thin male patient or the 16-year-old boy who has acne. You should be thinking about ethambutol toxicity, and I try and make a baseline. They need to be testing their vision once a month by some mechanism. Someone has to check their vision, even if that's the patient themselves or their nurse practitioner or their direct observational therapy person. Somebody has to check their acuity, and I say also Amsugrid once a month. And the little e in the hate list, the erectile dysfunction agents, of which sildenafil is the prototype, and somewhere between 2.1 and 2.3x increased risk of NAION times a relatively small number, 2.8 to 11.8 per 100,000 vasculopathic males. And so when the Reaper, the God of death, comes for you or your patient, what shall we say? What shall we say? Not today. Not today. Not on my watch. So to me, defeating burnout, the Reaper of our souls, our professional souls, requires that we climb a second mountain. So here is that first mountain, and David Brooks calls the second mountain the way to defeat burnout. For physicians, is the same thing that David Brooks is emphasizing for the road to character and finding satisfaction. So my personal first mountain was all about me, my papers, my publications, my presentations. But over time, I have found that helping other people climb their mountain is a lot more fulfilling. So my second mountain is us. In fact, my second mountain is you. And that's why we're here. That's why you're sharing this time with me. You're here because you believe in that. Oh, so if you look at my first mountain, me, which is great. but now I'm on my second mountain. And if you look at my PubMed second mountain, climbing my second mountain actually helps me more. So I get more papers because I'm helping other people write their papers. So I don't have to be first author anymore and all these things. I'm so happy to share with other people the passion and joy I have for neuro-ophthalmology. And if that means they get to write a case report or an iWiki or something, then we get to climb that second mountain together. And so I'm so happy to be able to climb my second mountain with you today. Because the burnout, the physician burnout, when we're climbing that second mountain, we get to say, not today. Not today, you devil. Not today. Not my watch. I became a doctor to do this, but I became a teacher, not to teach, to inspire. And if I inspired you today to learn, that is what I consider true teaching. And hopefully you will now recognize the 5 medicines that can blind your patient and blindside you. And I thank you for your time and attention.
Thanks.
Fantastic. The chat box worked really well for the questions. Thank you very much, Dr. Lee, for answering them as we went along. And of course, we can open the floor for any additional questions that may have arisen.
I also walked a half a mile during the talk.
So you know what, for the sake of the recording, I will ask you some of these questions so that they're there for folks who watch the video afterwards, because the chat transcript does not get copied. But thank you for addressing those during the talk. I'll try to pick a couple of the more pertinent or relevant ones. Dr. Lichter was asking if there's a link between the COVID vaccine and NAION or GCA.
There's no proven association between NAION, optic neuritis, and the COVID-19 vaccine.
And actually, Dr. Lloyd was asking whether patients considering starting Viagra should have an ophthalmic exam to look for a disc at risk.
The structural disc at risk is present in so many people, it might make them nervous to find it. We don't use it as a screening. However, in patients who are about to start the agent, I do tell them about the risk of the structural disc at risk.
And to follow up on that, Dr. Epstein was asking if the patient has an NAION in one eye, do you recommend against these medications?
We are here to inform. The word doctor means teacher. So we're there to teach them about the risks, but people have to make their own choice. We must respect their autonomy and their choice. I have many patients who have had NAION in both eyes and they still want to use the drug because it's that important to them.
Fair enough. And Ike was asking, was there ever COVID in Texas?
There's COVID here, and we have more than double your cases in terms of deaths. We have 50,000 deaths. That's more than your whole country.
That's tragic, but I guess everything's bigger in Texas.
If it's not always better, but it's definitely going to be bigger.
And Dr. Lloyd was asking again whether there's any utility for color vision testing anymore.
Color vision testing used to be recommended in the previous versions of the Academy's screening guidelines for hydroxychloroquine. However, it's no longer considered to be necessary because it's so insensitive. However, it is still sensitive for other things, and so we use color vision in every patient in neuro-op, not just these people, to look for the other things. It's super sensitive for like optic neuritis and stuff, but you shouldn't rely on it for screening for hydroxychloroquine because the ring scotoma usually doesn't cause dyschromatopsia until very, very late.
Awesome. Very practical question here from Dr. Hatch. We see patients coming on and off Plaquenil all the time. And how do you quantify their risk?
So the risk factors all remain the same because the patient-related factors, the one that changes in the on and off is the dose and the cumulative dose. So you must calculate the cumulative dose accounting for the fluctuation in the daily dose. And so the cumulative threshold is 1 kilogram of cumulative dose. So you got to go back and say, when were you off? When were you on? When you were on? How much were you on? Ideally, machines would just do this and keep a running tab for you. This was the promise of the electronic medical record, that it would be decision support and provide smart tools and do artificial intelligence. And a pop-up would say, hey, your guy is at year 5, 1.2 kilograms. Do you want to do a 10-2 and a fundus autofluorescence and MERG, yes or no? Instead, you have to still do all this.
So as a corollary to that question, what do you do if a patient's hit that 1 kilogram dose, but they're otherwise doing well and their rheumatologist wants to continue the medication?
So I tell the patient and I tell the prescribing doctor they have moved into the high risk category. We go through the conversation again. Do you really need this medicine? How bad? If they say yes and the doctor says yes, we switch them to the high risk screening strategy, which is going to be at a higher frequency.
Another practical question here from Dr. Wright. Just when do you start screening for your plaque retinal patients? Do you start right away at 5 years?
The risk of hydroxychloroquine toxicity starts at year 5, but the cumulative dose might be reached earlier if they're on high dose and they're super short and super skinny. So you have to use both the cumulative dose and the duration. However, the chance of them getting toxicity before year 5 is low. However, because the American Academy of Ophthalmology guidelines say you should have like an eye exam every year anyway, you shouldn't go below what normal people get for just regular exams.
Perfect. And from Dr. Chinpuk, for the purposes of getting a 24-2 with the plaque retinal, could you define Asian?
Asian is a colonial construct and a geographic construct. There are huge differences between someone from Japan and someone from Malaysia, even though they're kind of both Asian. Similar to Hispanic or Latinx or any of these they're constructs, they're social constructs, not really genetic constructs. However, for the purposes of this talk, Asian means Asian subcontinent, that includes Indian, Pakistan, Bangladesh, and Asian continent, but maybe not Australia and New Zealand.
Okay, thanks for clarifying that. And Dr. Lloyd was asking, with ethambutol, we're checking the VA monthly, but how often are you doing formal visual field testing?
So as opposed to hydroxychloroquine, where you can have 20/20 acuity, because the ring scotoma is sparing that little hole in the donut, ethambutol toxicity normally hits the acuity and the color vision first. So as opposed to hydroxychloroquine, where the patients might not know they're getting the toxicity, ethambutol people kind of know they're going blind because it just goes right into the center right away. And so that's why the screening recommendations are just visual acuity. That's why the screening recommendations actually don't require a doctor. You can just check yourself, or the nurse who's giving you your direct observational therapy for TB can just check your acuity. So I do a visual field on them, but acuity is probably all that's necessary.
Okay, fair enough.
How reversible is ethambutol toxicity when you stop the drug? Does it have a recovery?
Yeah, so the things that provide prognosis on reversibility for all of these things, but especially ethambutol, are the retinal nerve fiber layer on the OCT and the macular ganglion cell layer on the OCT. So if you have a normal looking nerve, a green zone on the OCT, and a normal macular ganglion cell, you're going to get your vision back. If you're in the red zone on the OCT, nerve fiber layer loss in the papillomacular bundle, you have serious loss on macular ganglion cell, and your nerve is pale, well, you ain't getting your vision back now, are you?
So Andy, we have some interesting characters in our department. So I've got some good questions for you here now. So Ike is he's asking for a friend, of course, whether they should be taking the Viagra in the morning to avoid the nocturnal dips.
I think that your friend Ike might consider morning or afternoon delight to reduce their risk. Also, the alcohol consumption is a known co-risk factor, and obstructive sleep apnea. So there's certainly good recommendations and possibly anecdotal other reasons for a daytime encounter.
And Dr. Chinpuk has an anthropological question. So South Asians and East Asians have different anthropological definitions here. Why is the retinal response similar?
I think that's the social construct thing. So if you get shorthand Asian, you end up with, this is what we do in Asians. The same thing has happened in Hispanics, but you know, and I know, and everyone knows, there's a huge difference between Afro-Caribbeans, African Americans, and Africans. That's the reality, though. They're all characterized as Black patients or brown patients, but the color of your skin and the amount of melanin in your skin is not the determining risk factor for the toxicity or anything. However, that's what people see and that's what people use. As you know, many journals have asked us to remove these things. So you can't put white male unless it actually makes a difference to the paper. So they just take it out.
Yeah, and there's a final interesting comment here from Ike, just talking about the difference in keratoconus risks in East versus South Asians. So,
there's clear differences between even amongst Asian peoples. I mean, we're not a monolith. I'm Asian, but I do not speak for Asians. We are not a monolithic culture. We are not a monolithic people. The genetic differences between a Japanese person and someone in the southern part of the same continent is the same difference as a Japanese person and an African person. So it's just totally social construct, I guess is what I would say. But you're stuck with this Asian thing because that's what's written in the paper.
That's right. Well, Andrew, thank you for your time. And John, I'll allow you to close the session out.
It was fantastic, Andy. Thank you very much for joining us. Remarkable how well the talk went, both treadmill virtually, treadmill in real life, and delightful to have you here. Next time, I hope to be in person, and you can enjoy seeing some of your friends in Toronto in person. So thank you very kindly. It was a great talk and lots to take away from that. Very, very practical and very useful. This also concludes our formal academic grand round schedule for this academic year. And resident teaching, of course, continues over the summer. And we will see you all again in September for grand rounds resumption. Thank you very much, everybody.
Okay. Bye, guys. Have a good day.